Dah berapa minit dah?
Can you hear me, Prof?
Can you see it?
Yes, we can see your slide, Prof.
Okay, thank you very much.
Okay.
Sorry for delay. It's a bit miscommunication. I'm just finished my operation just now. So I thought 3 o'clock, but actually turned out to be 2 o'clock. Okay, the topic today, I basically prepared just to discuss more to the surgical, post-surgical pain. So how to manage persistent pain and how to prevent the potential patient suffering because of post-surgical pain. Okay. So basically, just a brief my aim for discussion today. I want to able to differentiate between acute pain and chronic pain, and then different type of pain, for example, nociceptive pain, and also the neuropathic pain. Basically, the incident of the persistent pain, basically, and then how you want to approach this kind of patient who are potential to develop post-surgical pain, but we call it persistent pain. And some say it become CRPS, some say chronic pain. What doesn't matter the definition, but how you want to approach this kind of patient. Throughout the world, basically the incidence of persistent pain is quite high, around 20%, and then the cost because of this is high. Some country 1,000 million per year. Some depend on how they do the survey. But the problem with this, some patient having the moderate to severe pain. It's unfair to them, and then become persistent, which later on develop to the psychological impact, social impact, and also economic impact. But the problem with the pain, as you understand, is you cannot measure objectively because it varies from person to person, and the way your assessment, and then the fluctuation of the pain score. Okay, so it can be because of genetic, it can be because of personality, and also because of what happened. And also because of experience before. And also the person itself who are managing the patient. So how you want to differentiate between acute pain and chronic pain? Okay, basically, as usual, acute pain you easily able to differentiate because it will become very easy in the sense that is you can see personally acute pain because it follow the pathophysiology and also follow the sequence, meaning that one, you can see the wound and the patient score of pain relatively correlate the severe of wound. So the acute pain easily or objectively easy to assess and also supposed to be easy to manage as compared to the chronic pain. Can you hear me or not?
We can hear you, Prof, but I think your slide is not in
That's
full
why I say
screen.
there's something wrong with the technique. How to do this one? You cannot hear clearly, is it?
We can hear clearly, but it's just your slide is not in full mode,
Okay.
not in presentation mode.
Okay, can?
Now is better.
Okay. In contrast to the chronic pain, the problem with the chronic pain is because there is the chronicity itself differentiate from the acute. One of the important factor for the chronicity because it impact the psychology of the patient per se. So the patient become depressed. So your assessment sometimes will be affected because of depression or become anger. So emotion also play a role in terms of intensity of pain. So it masking your assessment. So that's why chronic pain should be managed as a multidisciplinary. That's why there's sometimes certain center they have the psychology or psychiatry just to cater the emotion or the psychology impact, and also the element of bedridden, ambulation. That's why the rehab come across. So it become multidisciplinary and it become a bit difficult to manage. And by definition, it should be more than 3 months or 6 months. And then more than that, some patients become whole life. Some say the pain doesn't correlate well with the injury, but it depends. Some maybe yes, but some maybe not. So it depends on disease to itself. Some, for example, fibromyalgia, yes, it doesn't correlate well with the pain score, but some maybe yes, for example, the joint pain. So it depends. So that's why let the expert manage that kind of things. Okay, what difference between nociceptive pain and also the neuropathic pain? Well, the important here, nociceptive pain, you can follow the dermatome. You can follow the referred dermatome, but neuropathic pain usually very difficult because it doesn't, even though the term neuropathic pain coming from the nerve, but it doesn't follow well with the dermatome. Some, because one of the reason, the nature of pain itself. If for the nociceptive pain, you can understand sharp pain, okay, dull aching pain. But neuropathic pain, sometimes the description also weird. For example, numbness. Once you say numbness, you very difficult for you to demarcate, meaning that locate where the pain is itself, because numbness can be distribute everywhere. And also some patients will complain about the hand crawling. So the term itself is jargon, and for you to differentiate in terms of the dermatome, it becomes very difficult. Okay, so that's why some disease, especially for the cancer patient and some patient with a post-surgical pain, you have difficulty. That's why this kind of patients sometimes end up become persistent pain later on. Okay, for this one, you can differentiate between somatic pain and also the visceral pain. But for the neuropathic pain, sometimes they have their own term. For example, allodynia, hyperalgesia, so on and so forth. So this, the term itself, sometimes maybe some of you maybe first time hear this kind of term. So furthermore, for you to manage this kind of patient. This is the common cause of or origin of nociceptive pain and also the neuropathic pain. You can see maybe a few patients, for example, trigeminal neuralgia, pattern limb pain in orthopedic, so on and so forth. But CFPS, so on. But having said that, cancer pain sometimes mixed with a nociceptive pain, and neuropathic pain. Okay, the pain cycle very not clear. Okay, but the problem with the pain cycle, you can see the psychosocial element, emotional element, physical changes. So these are the cycle correlate with the patient. So for example, depression, patient doesn't want to ambulate. Okay, even physical also sometimes causing the pain, emotion disturbance. So this cycle, it become over the time become deconditioning. Deconditioning meaning that worsening over the time. If you don't break this kind of cycle, it's very difficult for patient to become pain-free. Before you go on, you must have in mind the element of red flag. Okay, whether the pain itself coming from something else, in that something disaster, for example, cancer or nerve injury or something you need to further investigate, or infection, because sometimes you look for one aspect, but actually there is another aspect which are coming together with the first diagnosis. So it's very important for you to rule out the red flag before you go on, because sometimes the red flag may be a disaster later on coming. So for example, drug abuse, for you to start the medication while this patient persistent having pain, but actually this become tolerant for other drug. Okay. So how you want to approach patient day-to-day basis? Of course, in our undergraduate approach, you have to collect the history, you have to do physical examination, and then you have to rule out the pain, and so on and so forth. And you have 12 criteria for managing the or look for the pain itself. But what I want to share with you how to approach this patient, especially for the surgical scenario. First, you must look for the patient. What kind of personality of patient itself? Is it nature low threshold or high threshold? So that element is very important. This one you can elicit based on your communication. Some patient is very opioid naive, some is not. Some is very low threshold, some is not. Okay, so this determines how aggressive you want to manage the patient. That's one thing. Second, if you see the patient in the clinic, and you know this one minor operation or major operation, okay? Or some patient maybe have the pain before the operation, some may be pain after the operation. So this determines also what kind of pain management you want to perform for this patient. If major operation, is it patient will be ambulate or not ambulate after operation? So the one are the important thing, because if patient doesn't ambulate, then you have lose one element of blood flow. In that if patient doesn't ambulate, the wound healing can delay. It doesn't matter what the reason why the patient not ambulate. So this will determine how fast how high aggressive you to perform the major operation. You have to contact the APS, acute pain service, before the operation, because you want to settle the pain once the patient healing well. Usually the most painful experience by the patient, either one patient fully awake, second, one patient start ambulate. Okay, so far are you clear with the sound and then also the presentation? Hello?
Yes, bro.
Okay, so if you understand this concept, this is very easy. Okay, if patient, for example, laparotomy, okay, so definitely post-operative, day 1, day 2, patient not ambulate. Okay, so how major the laparotomy? Is it because internal obstruction or is it because of cancer? So the manipulation internal organ also play a role. Okay, so if this kind of patient, then you understand, definitely day 3, the patient maybe start ambulate. Okay, the APS, the problem with the APS, sometimes they are allocated for 2 days only, 48 hours. So when you want to refer for APS, okay, the things you need to communicate with the APS team. We can extend the APS provided case-to-case basis. Okay, even though the APS survey usually lasted for 2 days, but it depends on patient also. So how far you want to go? If you want to ambulate patient day 3, the PCA doesn't play very well because the PCA itself make the patient be unable to ambulate unless you have a portable PCA. Okay, so this is the thing you have to communicate. And then usually you doesn't want to give IV form because you want patient ambulate. So this is the thing you need to understand, the concept of the ambulation. Then when you want to start physio, even the patient bedridden, still the physio can be utilized. The physio in the beginning help the patient in terms of first, blood flow. Second, the joint stiffness. Third, the mobility of the muscle. So usually if you start physio early, the patient can ambulate faster. As compared, you ask the patient or to have the physio day 3, for example, when you start ambulate the patient. So this can reduce the pain for the patient. And you must understand the nature of pain itself. Some patients have the pain intermittent. What do you mean intermittent? In the morning, and then throughout the day, pain-free, or very minimal pain, evening. Or some patients have the pain, for example, evening 6/10, afternoon or after that around 3 to 5. So meaning that this kind of patient is a continuous pain. So this is what I want to tell you about how you want to manage the pain with the baseline medication, and also the interrupter, or what we call it as the play-up pain. How you want to manage between these two? Okay. So what your aim for the managing this kind of patient? Is you want to give oral or you want to give IV? Which one better? How you want to modify the different type of analgesic, and when you want to utilize opioid? Overall, until now, the pain management, even though we have acute pain service, still we have 30 to 60% patients suffer from moderate to severe pain. Okay, that's why sometimes you become must be target pain management must be reasonable. Sometimes we not aim for the pain-free, but we aim good pain control, meaning that patient doesn't suffer much and they don't have the trauma about the pain experience. When I mentioned to you just now, you need to know the patient. This is the reason. Okay, some patient having very low, for example, starting with the injury, and then because of injury, what is it? Is it trauma? Is it cancer? Is whatever cause? Patient having the pain. If patient are very high tolerant, they don't worry about the pain so much, meaning that they start ambulate whatever pain. But some patient, meaning that they fight with the pain, and they ambulate very fast after the operation. But some patients who are easily traumatized themselves, meaning that Because of pain, they think a lot, they worry a lot, and they doesn't want to move at all. This kind of patient have a negative emotion, and then asking a lot, cause so much disturbance in terms of themselves, family member, and also the healthcare provider. And they usually easily become depressed later on. They doesn't want to cooperate with you, so that your management will be affected. Okay, so this kind of patient is very difficult. You must know from beginning. And this patient manipulate a lot, and usually this pain will become very worse. Okay, so just now I'm talking about the flare-up pain and also the continuous pain. So you must understand about the concept of pharmacology, which group of drug you want to use, and you must understand about the duration of action and the reason behind, meaning that the pharmacokinetic, pharmacodynamic. So we have the WHO analgesic ladder, and we have the step ladder according to the pain score, from the mild, moderate, and to severe. And we have also the adjunct therapy of pharmaco. Okay. So each step of ladder determine the strength of the analgesic correlate well. Okay. But having said that, it doesn't mean for you to use step ladder very rigid. Okay. For example, for you think about the paracetamol is nothing. Okay. But now the era of polypharmacy. So meaning that even paracetamol have their own role. One of the reason is because you have the different mechanism of action. And this drug quite safe in the sense that you can compare with other drug, rarely having the drug interaction. This is another drug been abused a lot. Okay, so in the sense that very fast action, but it's very dangerous for long term. That's why some say 5 days. It depends actually. It doesn't mean 5 days per se. It can be 5 days, meaning that you use today, tomorrow you're off, the other day you use. Later on. So it doesn't mean use continuous 5 days. If you use 1 day, skip another day, later on still become dangerous. Okay, so this another drug. Just now is NSAID. This one a COX-2 inhibitor. What difference between these two? The COX-2 inhibitor more or less safer as compared to NSAID, in the sense that it less cause the still irritation, less cause the bone healing, poor bone healing or osteoporosis, less cause renal problem or exaggeration of asthma, a cardiac problem. It's not 100%, but safer. That's why some of this drug we can use longer compared to NSAID per se. What about tramadol? The problem with the tramadol, sometimes we worry about the nausea, vomiting. The tramadol is good for the patient who are having more toward the aching pain as compared to sharp pain. And then relatively safe in the sense for other organ, for example, GIT, renal, cardiac, so on and so forth. So this one you can use longer without worry so much. Now we have the combination, we call it Atrasec. It's a combination between paracetamol and also tramadol. Usually we use this kind of drug for the moderate pain. Rarely we use for the severe pain. But as I mentioned before, we can combine with other drug. So tramadol with the paracetamol we call Atrasec, but we use also tramadol with other drug, for example, opioid base. This is a taboo for most of us until now. We worry about the addiction, we worry about dependent, we worry about the constipation, we worry about the residual depression, and so on and so forth. Okay, mind you, as long the patient having pain, not to worry so much about the dependent. You must worry over the time. When the pain start subside, the wound start better, the patient start ambulate. Then you start thinking about the potential patient become dependent. That one usually more than weeks after you use continuously. As long as patient in the ward and patient not come from the manipulative patient type of patient, so don't worry so much about the dependent. So this basically equivalent dose, meaning that the potency. That's why you use 100 mic of fentanyl equivalent to 10 milligram of morphine. That's the meaning of that. Okay. As I mentioned, the potential for patient to develop dependent addiction is very low as long as patient in ward, not patient you discharge through the clinic and then still utilize the opioid. Unless you are familiar with the drug, you're familiar with the patient, then it's okay. But if you're changing the MO of the surgeon to manage the same patient, then you should worry. Okay, this is the thing we're talking about, the persistent pain. Okay. The persistent pain correlate with the type of surgery and also the how much the manipulation occur during surgery. Okay. So how the surgical or the wound, the trauma can lead to the chronic pain. One is the procedure itself. Sometimes the procedure extends beyond the boundary, meaning that, and then another issue is the potential anatomical variant. So without you are aware, either you cut directly the nerve or the wound itself healing and cause fibrosis surrounding the nerve. So this can cause persistent pain later on, either the direct nerve injury or later on. So that's why we call it periphery sensitization or central sensitization, because the persistent pain over the time. So how you do approach this kind of patient? First, as mentioned before, you must know the patient, you must know what kind of operation you want to do, and then how you want to prevent from the sequelae after the operation. So either you minimize the operation, the wound, either change from open operation to the laparoscopy first. Second, you can use a regional block for that kind of procedure. Either you use a local infiltration or you use the regional block. So for the regional block, it can be from the skin, you block from the nerve, peripheral nerve, you can block at the spinal level, you can block at the central level. So it depends on the how you familiar with, you ask for that. For example, for the skin level, local infiltration. At the peripheral level, peripheral nerve block. At the central level, it can be spinal, it can be epidural. Epidural can have different level. Or you go to systemic block. This one of the important block you can utilize during the operation, before the operation, or after the operation. So this type of the regional nerve block I'm talking just now, how you want to utilize it. So depend on the place or surgical site you want to do operation. This kind of patient you must aware, meaning that they have their different agenda. But usually for you maybe difficult because of the you see a patient during the clinic operation different person, in the ward different person. If you aware, then you're aware. If not, you have multiple team, then you have difficulty to see potential manipulative patient. So when you want to consider, you need to refer to the team. First, the patient who are utilizing the opioid before. Second, when you manage the patient, you see the patient fully respond in terms of pain score, in terms of improvement overall. Second, you encounter patient with a neuropathic pain, or you are unable to pinpoint where the pain coming from. Meaning that you see the surgical wounds healing, but the patient still having the pain. Or you see have the frequent kind of patient. And some patient already abused drug before. So this kind of patient you need to refer to appropriate team. This basically the summary overall patient who are potential to become persistent pain. Patient who undergone surgery at the early age. This is not a gender bias, female potential. Patient who are already have the chronic pain before, or patient who are psychological vulnerable, who are usually stressed, anxiety, depressed, patient who are previous history of cancer, or potential patient with diabetes or with frequent infection, certain disease, or genetic. What kind of operation you want to do, as I mentioned before, the way you do the operation, as I mentioned, whether manipulative or not, laparoscopy or open, so on and so forth. The duration of operation itself. The most important thing is a post-op pain. The more severe the post-op pain, the potential patient become persistent pain later on. And also the severity plus neuropathic pain, higher, or the pain score need to use opioid base, it will be potential to become persistent pain later on. That's why in our setup, we have many interventions to overcome this kind of issues. APS per se have different mode of delivery of drug, either through the regional block, either through the PCA infusion, various modality of analgesic. And we have also performed certain pain intervention procedure for the certain patient, usually for the cancer patient. This one of the few procedure we do, and also depend this one for the cancer patient. We use intrathecal opioid, sometimes delivery, sometimes we give PCA tunneling. So we can perform this kind of procedure, but we want basically for the quality of life and the patient for the cancer who are good prognosis, meaning that within 6 months or more, the outcome life expectancy is too short, and then the procedure is not worth to perform. And then, okay, so maybe some patient need acupuncture, but this one very minor case. Okay, so far, any question you want to ask?
Any questions from online attendees?
Any question? Any question from the floor?
Prof, we've got a question.
Your experience doesn't matter. You want to share or you want to discuss?
For cancer patients,
Yeah.
is fentanyl patch better than opioid morphine, or how do you?
I won't say.
Modality.
I would go person to person or patient to patient rather than what the best modality for the patient, because especially for cancer patient, the pain changes over the time. It can be because of the spread of the disease itself or other reason. For example, patient emotion also play a role, and even the pain also change over the time. Today it can be sharp pain, tomorrow it can be dark aching pain, the day after it can be neuropathic pain, or the day after it will come mixed pain. So that's why for cancer patient it's very delicate. It's more toward patient. We have to monitor patient again and again. But the most important thing for this kind of cancer patient, first we want to know, is it pain is intermittent, or is it continuous pain, or is it mixed? And then our expectation and the patient expectation is different. Some patient, we ask the cancer patient, what the most thing you want in terms of managing pain? I want to sleep at night. See or not? It doesn't bother about the pain score around 8 or daytime, but the pain score around 6 at night is troublesome. Patient cannot sleep. So we manage patient case to case. At the end of the day, what the quality of life they expect. Some patient doesn't bother, the pain score is so bad. I want to drive to see my family and then having fun. So sometimes it's beyond our imagination what the patient wants. So it's case to case basis if you want to manage the cancer patient. Some patient doesn't mind much, but the constipation troubles for them. That's why they say, doesn't bother, the pain score high, I don't want to use opioid. But now the technology different. Now we had the Tajin, for example, which cause less constipation. So this thing changes over the time.
All right, thank you, Prof. Any other questions?
You can ask about cancer because I was trained also in palliative before, not oncology per se, but palliative. Palliative is changed a lot. Before palliative solely about the cancer, now palliative go to the heart transplant, lung transplant, so on and so on. Even chronic renal disease also part of the palliative.
I've got another question, Prof. In terms of weak opioids, patients, I think we don't like using tramadol because of the side effects. Any other weak opioids available in Susmac that we can actually use? Codeine, dihydrocodeine, any other types of?
First thing you have to understand about the tramadol can be under opioid, it can be not under opioid. Okay. If tramadol is troublesome, you can use Atracet. As mentioned, Atracet is combination between half tramadol and also the paracetamol. That the lower from the tramadol itself. And then what kind of side effect you worry? Sometimes we are waiting for the side effect coming first, they want to treat the side effect. If you think about the tramadol causing nausea, vomiting, why not you give together tramadol with Mezolone? Something like that. Or you ask the patient to take Mezolone first, then you take the tramadol later on. So that's kind of the preventive measure. That's one thing. Second thing, you must understand what kind of pain you want to treat. Is it nociceptive pain, or is it even nociceptive? You must understand, is it sharp pain or is it dark aching pain? Tramadol effective for the dark aching pain rather than for sharp pain. So sharp pain, I would suggest you use Celebrex, Acoxia, something like that. Okay. So you have to understand what kind of pain itself. And then is it persistent pain or is it intermittent pain? Is it intermittent pain? You can use morphine syrup, because syrup morphine doesn't mean you have to use 10 milligram. You can use 5 milligram, you can use 2.5 milligram. So you have different dilution. Even equivalent to morphine, you have the Osinom. Okay, so you can use a lot of things provided you understand when you want to use, why you want to use.
All right, Prof, thank you very much. Any other questions? I think if not, I'd like to thank Prof. Adi for spending time with us.
Prof, I got one more question.
Oh, okay, sorry. Okay,
Yeah.
go on, Jane.
If patient is a heavy cancer pain, as a palliative patient, and that is a naive morphine. So how should we start the opioid for this patient, and then how fast we can increase the doses? Secondly, should we start the prophylactic medication, for example, like Toulouse of Mezolon, because one of the complications is vomiting and also constipation?
Okay, if opioid naive, for example, you can use low dose 2.5, because 2.5 morphine or Osinom syrup form, we have 2 hourly, 4 hourly, 6 hourly, 8 hourly. So you see the duration of medication. That one thing. Either regular dose or PRN basis. That's why you must understand when pain was so severe. Okay, so that was one of the way. Second way, you can use 2.5 milligram for hourly, for example, as a baseline. Then you counter with another medication. For example, you can use Celebrate. So that's why you must understand what kind of pain the patient suffering. If the patient suffering on top of nociceptive pain plus neuropathic pain, then you can add an adjunct drug. For example, gabapentin, pregabalin on top for that. That's why some patient doesn't have pain-free. It's not because the pain is not free, because they have another type of pain, neuropathic pain on top of nociceptive pain. This is very common for the cancer patient. This causes the patient having persistent pain because you only manage one type of pain, but you doesn't look for the other pain, which is the neuropathic pain. Okay? May I answering your question?
Yes, Prof. And then should we start like Toulouse and Mezolon for patient with morphine?
If patient is not opioid naive, you don't see the naive patient, you can use Tajin combination, Mezolon, naloxone plus the oxycontin. So usually this Tajin less constipation for the patient. If the patient naive, then we have to use morphine, syrup morphine. Then this kind of patient, I would suggest in the beginning, start the Mezolon TDS, for example. It's no harm.
Thank you, Prof.
Okay.